I'm Karen Parry, manager of the East Brunswick Public Library's Just for the Health of It initiative. Just for the Health of It is a series of programs and services to help everyone in our community lead their healthiest life possible with the right information. Today we are featuring Dr. Ira Merkel, a professor of medicine at Robert Wood Johnson Medical School and also a practicing gastroenterologist right here in East Brunswick. Dr. Merkel will talk about how to speak to your doctor so that patients can maximize their time with their doctor in the new age of healthcare. I think you will find his performance highly enlightening and very informative.
A couple of ground rules. First of all, we're not going to talk politics, though politics may come up. Second of all, this isn't the Dr. Oz show. This isn't the doctor show. I'm not here to make a diagnosis in 50 words or less. Okay, I want to try and make this interactive, and I hopefully will leave enough time to answer some questions. A disclaimer, these are my thoughts. Okay, I don't represent my private practice group, the university. These are things that have been bugging me that I figured if I can get out to the general public and make them aware of what's going on, maybe everyone can benefit from some of my experiences. I've been in practice for 26 years. Initially, I was in University of Pittsburgh on faculty there. We came to New Jersey. I joined RCHP, HIP, so I worked in a staff model HMO, and I've been working in this private practice group for the last 20-something years. So I like to think I've seen the gamut. And the problem is, medicine is broken. I don't have a good fix for it, but it's broken. And in order to survive in this climate, you need to become much smarter. As I wrote up there, medicine isn't a calling anymore. Medicine is a business. There's no such thing as a doctor-patient relationship anymore. Right now, I'm a healthcare provider, and you're a consumer. It's a shame. I certainly don't run my practice that way, but that's really the reality of the situation. And once you embrace that reality and understand it and try to deal with some of the changes, everyone can benefit, and really you can get the best out of your health care. It's interesting. We used to have the image of Marcus Welby, MD. I'm showing my age. I'm sure most of you remember Marcus Welby, the elderly doctor. Patients felt that they were going to see the great healer and that Marcus Welby was doing them a favor by taking care of them. Now it's always a question of who's doing who a favor. I always feel like the patients say to me, I'm doing you a favor coming to the office. And I say, really? I thought I'm supposed to be helping you. Well, how do I express that? Somebody calls up and says to me, I need to be seen today. It's an emergency. Okay, come in at 1 o'clock. Oh, that's not convenient for me. All right, come in tomorrow at 12 o'clock. Oh, no, I got to have a haircut appointment. It just blows my mind sometimes when I think about how people really don't understand and put a value on their health care. But it sort of minimizes the doctor-patient relationship when you have that type of interaction. And the reason you need to understand why it's a business is because, and this is going to come as somewhat shocking to you all, medicine is the only business in the United States, probably the world, where the annual overhead goes up and the reimbursement goes down. You call your lawyer, you call your auto mechanic, you call any one of a number of people. Each year, the bill goes up. You pay more for the same services. Not doctors. We get lower reimbursement every year. Medicare cuts our fees for us providing the same amount of service. So you sort of have to say to yourself, do I want to lose money? No, I don't want to lose money. So what am I going to do? I have to see more volume. If I'm seeing more volume, how am I going to do that? I don't want to work longer hours. Oh, I'll spend less time with my patients. Or I'll do my procedures in a little bit more rapidity. Oh, I may not be as proficient. Now, I'm not saying that's me, but I'm just telling you the reality of the world. So when you notice that your doctor's always rushing you in and out of the office, or that there's a big lineup in the waiting room waiting to get in, it's because the doctors have to do volume. It's the nature of the beast. And you know something? Patients don't really call half the time to cancel their appointments or say, I'm going to be late. They just don't show. Well, that frustrates the doctors because then the doctor could use that spot to fill a patient. Or if somebody calls me in my office and says, can I come in, it's an emergency, and I look at my schedule, I don't want to have my patients wait who are scheduled. I said, no, I'll see you tomorrow. But if somebody called me up and said, hey, listen, I'm canceling, you could use that spot for someone else, I might have been able to squeeze that in. So there's a disconnect. We're really not communicating very well. And that's really what we need to understand. Because another thing you need to understand is that the government is changing the way doctors are being paid. Okay? Right now, it's still fee for service. You do a job, you get paid. In the near future, it's going to be pay for performance. So in other words, the doctors are going to be paid based upon certain criteria, certain guidelines that they're going to have to meet, and that the government is going to decide, okay, you met those criteria, we'll reward you. We'll give you 1% more. We'll give you 2% more. Or you haven't met those criteria, which means we're going to deduct 1% or 2%. Well, what does that mean? The government is deciding how you're going to be practicing medicine. The doctors are going to have to meet certain criteria. And really, these guidelines are going to maybe somewhat arbitrary, but you need to be aware that that's the way things are moving. And what's the key bottom line? Cheaper cost. These guidelines are supposed to allow you to practice medicine at a high quality, at a cheaper cost. Well, folks, there's a point where the rubber meets the road, and you can't do things any cheaper at a cheaper cost at a high quality. Something has to give. So, I mean, there's a lot of things going on. I'm sure all of you have been frustrated, and my patients as well, when you go in to see the doctor's office and he's sitting there. And they're not even looking. Sitting there typing. That's called the electronic medical records, the EMR, or electronic health records. That was put into play as part of the Affordable Care Act because intuitively it made sense. If we put everything on the computer, this way all the computers can talk to each other, and this way you won't repeat studies or labs or tests. One computer can contact the other computer and get all the information. Seems like a great idea. And you know something? The government made it even more attractive to do it because they gave doctors incentives to go out and computerize your office. So my office the first year, we got $44,000 to sit and put in a computer system. You know what? Cost me twice as much with the training and the headaches and all the aggravation. We ended up changing my computer company. We ended up going to another computer company. Here's a dirty little secret. Do you know Dr. A's computer doesn't communicate with Dr. B's computer, doesn't communicate with Dr. C's computer? The only way the computers connect is if you're on an enterprise system. So Robert Wood Johnson, for example, has an enterprise system. So all the doctors part of that enterprise system, they're able to look into the computer. Meridian Healthcare, Summit Medical Group, they all have their own enterprise systems where they can communicate. But it doesn't matter because if I'm getting a patient from another doctor, I still don't have the information available to me. I'm in the cloud. Some of my colleagues are in the cloud. I can't get into the cloud to get their information. So how do I have to get the information? I have to call the doctor's office, ask them to fax it over. Well, they fax it over, but since my computer is in the cloud, it goes into the cloud. Somebody in the cloud, whoever sits in the cloud, I don't know who sits in the cloud, decides where that's going to be faxed. It faxes it down to me, and then I have to open it up and sort of move it into someplace. Okay? So even though the EMR looks intuitively nice, it doesn't work. It slows you down. People who come to my office, I see a couple of my friends, not my patients, but my friends. I like to think of them as my friends. They're my friends, right? Thank you. Good answer. They will tell you, I sit there with a headphone and I talk into the computer. I have a voice recognition. Well, why do I do that? So that my notes have some meaning. Because I could sit and generate a computer note by checking off boxes, meeting the government regulations, and you know something? I'll get paid for that visit. It will be worthless to me. Because if I ever open it up, it'll tell me nothing about what's going on with the patient. So I have to do extra work in order to make the note valuable. So, I mean, there's a lot going on that's working against us here to try to really do a good job, both as patients and as doctors. I mean, I don't know how many of you people see primary care physicians anymore, but you know something? The primary care doctors, the family practice doctors, the physicians extenders, PAs, nurse practitioners, and then you got the hospitalists. Well, the hospitalist is the biggest racket known to man. Okay? Kills me. What happens is you see a doctor in the office, you get sick, you go to the hospital, you never see that doctor. The hospitalist takes care of you. Who's a hospitalist? The hospitalist is somebody who's assigned to be in the hospital to take care of the patients until they get discharged, and then you go back to your doctor. Well, ideally, for the system to work well, the patient should be getting admitted to the hospital. The hospitalist calls up the doctor who knows you, he or she sends the records to the hospitalist. The hospitalist then generates information in a chart based upon that. And then when the patient gets discharged, a discharge summary should go back to the doctor. That's the ideal system. It doesn't work that way. If you speak to most of your primary care physicians, they'll tell you that I didn't, and you say, did you know I was in the hospital? No, I didn't know you were in the hospital. No one told me. No one called me. No one looked into it. So where's the continuity of care? Continuity of care, I love that term. That's like one of the dirty lies right now of what's going on in medicine, is continuity of care. Unfortunately, there isn't. You need to make sure that you're being taken care of. The doctors are too busy. They're not getting the help that they need. They're not getting the support that they need. They're not getting the communication that they need. In addition, the patients are being bombarded with just a wealth of misinformation. Okay? WebMD. Okay? You get on the thing, you read it, you think you're dying. And then you start treating yourself. Because then you go to the pharmacist and say, I read this on WebMD, and the pharmacist said this to me. And what do you think? The pharmacist said, well, let's try this, because now the pharmacists want to start giving out information and adjusting your medication. You know, I still remember, as I said, I'm a gastroenterologist. I don't know how many of you, many moons ago, Dr. Oz did a TV show about your bowel movements. And he said, unless you're having S-shaped stools like Superman, something's wrong with you. My phone was ringing off the hook the next day. My stools don't look like S, they look like Y, they look like Z. What's going on with me? I mean, you have to understand, people are out there to be provocative, to sort of get you worked up. And this way you'll pay attention, you'll watch more, or you'll call them up, or you'll do something. There's just such a wealth of misinformation. You have to be careful about what you read and what you see. And I'll talk about it a little bit more as we go on. So I've sort of quickly laid out some of the problems. So let me see if I can give you some of the solutions, okay? So as patients, what can you do? The first thing I like to sort of put down is know thyself. Nothing frustrates me more than when a patient comes in and they don't even know why they're coming in to see me. It happens. Dr. So-and-so said I should come in to see you. Well, why? Well, didn't he send you the records? Didn't he call you? No, Dr. X never calls me. Here's the thing. 9 times out of 10, Dr. X never calls me. Because you know why? Dr. X doesn't have the time to call me. Dr. X has to have his office staff find my phone number, call me, wait for me to get on the line, which is not that difficult. I usually get on the line, and then spend an extra 5 or 10 minutes speaking to me. Well, that means taking away his office staff from doing pre-certs or calling in other things or answering other messages. Takes away time from him seeing patients in the office. So I seldom get a call about discussing a case with another doctor. All right? So you need to know what's going on there. Remember, I said to you, you have a limited amount of time to get in and speak to the doctor. If you come in and I have to spend 15 minutes figuring out why you're there, chasing down your labs, getting your old records, then that's 15 minutes less I have to spend with you. Time is money. Time is valuable. When it comes to your health, time is valuable to your health. Okay? So if you're coming in my office, you need to know why you're there. That's number 1. Number 2, know the medication you're taking. Okay? It's funny because I just stole this 12 thing. Number 1, why are you prescribing this specific medication? Nothing makes me more angry and frustrated. I say to the patient, so what are you taking? I'm taking a blood pressure pill. Well, what are you taking? Oh, it's a little blue pill. I said, you don't know what you're taking? Oh, the doctor gives it to me. I say, is the doctor swallowing the pill? I said, if the doctor's swallowing the pill, then you don't need to know what it is. If you're putting it into your system, you need to know what you're putting into your system. Okay? Know what you're taking. Know the side effects. Know your allergies. Nothing makes me flip out more. I say to the patient, have you ever had a colonoscopy? Well, I'm not sure. I mean, what do you mean you're not sure? Somebody took a tube and stuck it up your backside and you don't remember who did that? I said, either you had it or you didn't. You may not remember the name, though. I'd like to think if somebody did that to me, I would certainly get the name, number, and license plate. But still, you've got to know Be educated so you can pass on the information to your physician. Come on time. Please come on time. I don't run late. If you walk into my office, and again, the people who know me will tell you, there's maybe one person sitting in my waiting room, and you're next. All right? I don't like to run late. I don't like to overbook. But if you have a 1 o'clock appointment, come in at 10 to 1. Come in at 1:15 to 1. Fill out the paperwork. When you make your appointment, say, what's the address? How do I get there? Should I put it in my GPS system? Let me tell you something. I have the 2 offices in Middlesex County that do not exist on the GPS system. If you put my addresses in, you'll end up God knows where, but you won't end up in my office. And my office staff knows to tell the patients, don't put in the address on the GPS. Use this address. Again, I said, know your medical history. If you want me to go over your lab work, bring copies of your lab work. Okay? My wife is here, she will tell you. I've chastised her many times when I said, so did you bring the lab work to the doctor? No, he said he's going to send it over. I said, did he send it over? No. Again, it's more time. It's the office staff. There's plenty of ways it could go down the tubes. You need to take responsibility. I went to see a physician today. He says, well, I'm going to call and get your CAT scan. I said, you want a copy of it? He says, you have it? I said, yeah, I brought it with you. Brought it with me. He said, oh, that would make it easy. Let me just go copy it. So I save time in that interaction. You need to be ready. You have to come loaded for bear. Make sure your gun is full of bullets so that when you're there, you can rapid fire all the information that the doctor needs to assess and figure out what's going on so they don't need to waste time. In addition, you need to prioritize your time to maximize your time. If you're coming in with 10 million problems, pick the top 2 you want to talk about. You're not going to get everything taken care of in the first office visit. Even if the doctor has a 45-minute spot set aside for you, pick 1 or 2 things that are bothering you the most and focus in on those 1 or 2 things. And then you say to the doctor, hey, listen, when we set up a follow-up visit, I'd like to talk to you about some other things. Is that okay? Sure. The doctor will appreciate the fact that you haven't bombarded them with 10 or 15 different things. You just can't do a good job. You need to be able to focus in on certain things. There's nothing wrong bringing a companion, or what I like to refer to as a listener. Okay? Sometimes the doctor says something and you're spacing out, or you're thinking about your next question and you certainly don't hear what they say. If you bring somebody there to listen who can take notes as well, then this way you have a second pair of ears in order to go over things, review things. And it's very funny. I love this. Again, people who come to see me will know this. When I sit in front of my computer and I dictate what I like to refer to as the assessment and plan, it's my overall impression of what's going on, what tests I want to order, and what the plans are. I have people come in and say to me, you know, you never said anything about that. I said, but you know, I dictated that in front of you. Oh, I don't remember that. I said, remember when I was on the headphone and I was talking out loud in front of you? Yeah, I said, that was for your benefit. Oh, really? I said, yeah, that's why I did that in front of you. So ask questions. You know, you have the right to sort of get your questions answered. And that's the important thing. Theoretically, you should have the last word before you leave your doctor's office. Okay? And when you leave the doctor's office, confirm a follow-up. I make a follow-up on every new patient I see, even when I know what's going on. I would say 60% of the time is to make sure things don't fall through the cracks. If I ordered lab tests or x-rays, I want to make sure you're back in the office to sit down and have a conversation with me, even if it's normal. And it's not to make money. It's to make sure things don't fall through the cracks. I want to make sure that if I started you on a medication, we follow through, make sure you don't have side effects, that you're tolerating it well, that we've made some changes that have improved your condition. But you need to make sure you have a follow-up. And you can't rely upon the computer. Here's another one I love. Don't assume anything. If I had a nickel for every time patients still say to me, oh yeah, I did the test, I didn't hear from the doctor, I assumed everything was okay. I go, what? What world are you living in? No one, you can't make that assumption anymore. You want to assume something? The doctor didn't get the test. It's sitting somewhere on his desk. Some nurse threw it into a chart. It got put into the wrong doctor's queue. How could you make that assumption? Anytime you have a test, you should get a call. It's either good or it's bad. It's either abnormal or it's normal. And you should have your explanations discussed with you. Now listen, let me explain something to you. If there's something that needs to be discussed and you want to have a conversation on the phone, if it's a 1 or 2 minute conversation, that's fine. If you want to have a 35-minute tete-a-tete, that's really not fair to the doctor or the patients in the office. Okay? If the doctor calls you in to set up a follow-up appointment to go over things with you, there must be a reason, and that's appropriate. Remember, your lawyer charges you for phone time. Your doctors don't charge you for phone time. So in other words, understand when they're calling you in to have a conversation, it hopefully is something realistic that they need to discuss with you. Follow recommendations. You know, I'm stealing this line. Albert Einstein said that the definition of insanity is doing the same thing over and over again and expecting a different outcome. If the doctor's making a recommendation to you and you're not following the recommendations and you come back to the office and you're not feeling good, well, what do you expect? I mean, you know, that's a perfect example. It took place last week. I had a patient who has this esophageal problem. He's taking an acid medication. He feels great. He stopped the medication. I haven't seen him in almost a year. One of my partners had to go in the middle of the night and fish out a piece of steak that was stuck in his esophagus. And he wanted to see me the next day. So I called him up. I said, so listen, you taking the acid pill? He said, no, I stopped the acid pill. I don't know why he stopped it. So I said, well, why'd you stop it? And he gave me the one answer that if you have children at home, no matter what age they are, will stop you in your tracks. He said, because I'm stupid. And once he admits that I'm stupid, I said to him, okay, I got nothing else to say. You proved the point. I said, stay on the medication, make an appointment to see me. And I said, and don't be stupid anymore. And he said, okay, we'll do that. We'll take care of it. You gotta follow through, especially if things are working. I mean, this is another thing that sort of cracks me up, and I think it's sort of unique to the times we're living in. I have patients coming in to see me now, and they're like surprised. And I said, why are you so surprised? They says, because I'm feeling better. And I said, so let me see if I get this. I can understand you're disappointed if you're not feeling better, but you're surprised if you're feeling better? Well, why is that? You came to me for me to help you, and I've helped you. Why are you surprised? Why are you not just satisfied? Well, because I didn't really think it was going to work, or I didn't really think it was going to make a difference. It's sort of hard to answer those type of people. I guess part of the issue is also have realistic expectations when you come to see your patients. You know, I have patients who come to see me, and I know it's a little late to talk about constipation, but I have people come in to see me and they say to me, you know, I've been constipated my entire life. I said, really? I said, yeah, 30, 40 years. I said, so how often do you move your bowels? I said, oh, once a week, maybe once every other week. Can you help me? So I said, I think we can make some difference. I said, but let me tell you right now, you're not going to have a daily bowel movement. And they look at me. But I'm coming to see you. What do you mean I'm not going to have a daily bowel movement? I said, you're 60 years old now? Yeah. And you've normally had a bowel movement once a week or once every other week? Yeah. I said, there's no magic bullet that's going to make you go from that frequency to every day to... I said, you need to have realistic expectations. If I can get you to have 2 bowel movements a week, we've made a big difference. Really? I said, once every other week? Twice a week? That's a big improvement. So again, the doctors have to establish expectations. The patients have to have their own expectations. Here's another thing that's sort of unique to the society right now. I see more doctor shopping than ever before. I have people come in to see me. I'm the 3rd opinion within a 3-month period. They've been scoped twice by Dr. A, by Dr. B, and then they come to see me and they say, can you help me? And I say, well, why didn't you like Dr. A or Dr. B? Oh, he didn't tell me, he couldn't help me. Well, why couldn't he help me? He told me that. Listen, there's a lot of times it's the wrong doctor for you. But there's a lot of times patients just get frustrated and don't give the doctor a chance to develop a therapeutic plan, and they leave. It's really not fair to the doctor. It's really not fair to you. I mean, it gives the doctor another chance to do a third scope, make some money. Though I can tell you right now, you'd be surprised how much money we make on doing procedures. Maybe I'll share that with you at the end. But it's really not fair to you, because you end up getting repetition of services, and you're really not giving a doctor a chance to sort of develop a relationship and see if they could sort of figure out what's going on. Again, if you have a bad experience, I have no trouble with you going to see another doctor, but sometimes it takes time to make a diagnosis and to come up with a plan. So I told you what some of the expectations are from you as a patient. What should you expect from your doctor? Aha. All right? Now, I know we're being taped, so this is going down in perpetuity, and I might be picketed and being chased with pitchforks and smoking sticks like the Frankenstein monster by my colleagues, but I think it's important just to sort of lay it out there. One, I think you're entitled to reasonable wait times. Okay? What's reasonable? That's open for discussion. But if you're going to be sitting in the doctor's office for an hour every time you walk into the doctor's office, I don't think that's reasonable. And listen, the doctors can run late. So I think it's not unreasonable for if the doctor's running late to have someone from the office staff stick out their head and sort of say, hey, listen, the doctor's running late. Emergencies happen. In other words, when I schedule my day, sometimes I go through my day real quick. Sometimes a patient takes longer than I scheduled time for, and I want to give the patient that time. Once in a blue moon, somebody comes in, needs extra time, I'll actually cut that appointment short and bring them back in a week or two just to finish the evaluation so as not to run too late. But you should have the expectations. Listen, as I say to patients all the time, your time is important, my time is important. We need to have that mutual respect. The doctor should explain their thoughts. Okay? And I think that's important as well. You don't want to have somebody sit there and try to blow smoke you know where. And I'm there every day. Okay? You want an honest assessment of what they're thinking about. Maybe they do know. Maybe it's clear to them. Maybe they don't know. And something, as a physician, you're entitled to say to the patient, hey, listen, I don't know. Let's do a workup. Well, let's investigate this. So, doc, what do you think it could be? Well, it could be one of a couple of things. Can you tell me what it is? Well, I don't want to worry you just yet. Let's work through these things. Is it something serious? No, I don't think it's anything serious, but let's investigate this. Okay? So see if you can get their thoughts and their ideas. Ask them what some of the alternatives are. Do I really need this? Is there something else we could try? Do I need to have this colonoscopy? Are there any other alternatives for having a colonoscopy? Sure there are. Let's sit down and discuss this. Do I need to have this surgery? See if there are other options. Ask the doctor to speak in plain language. You don't want to have them speak in medicalese. You don't understand it. It's a foreign language to people. And something? You have that right to ask them to explain it to you in something that you can understand. Hey, doc, is a second opinion needed? Any physician who says to you, no, you don't need a second opinion, think twice about that. Because something? Any doctor worth his salt, or their salt, shouldn't feel threatened if you ask for a second opinion. Because something? One of two things is going on. Either they're right or they're wrong. And if they're right, hey, makes them look good. If they're wrong, hey, we're human beings. You're entitled to make mistakes or not know. Just make sure if you're going to go, I tell people all the time, if I'm sending you for a second opinion, and I don't do it that often, but I do it, I'm sending you to one of the big muckety-mucks. I'm not sending you to one of the local yokels, okay? If I have a colonoscopy I can't do, or I think needs something more sophisticated, I tell people I got a guy in the city. He's not one of the best in New York City. He's not one of the best on the East Coast. He's not one of the best in the United States. He's one of the best in the world. Okay? So I'm sending you to one of the best in the world. Okay? Not the guy down the block. Not the guy down in the next town. Okay? So if you're going to go seek a second opinion, make sure you seek a second opinion from somebody who's an expert in that field. If I'm sending you for something that has to do with a motility problem, I'm sending you to one of the experts in motility. I got a guy who works in esophageal motility. This is his entire field, from the throat down to the top of the stomach. That's all he deals with, motility problems. He writes the textbook. He's in Philly. I use him all the time. He calls me up. He says, listen, I got friends living in your area. They have a problem with their stomach or their colon. I know nothing about them. I'm from here to here. Can you take care of it for me? Okay, if you got inflammatory bowel disease, ulcerative colitis, Crohn's disease, there are plenty of excellent centers. There's places you can go. If I'm sending you for a problem with the liver, and I practice liver disease, I'm sending you the guys who are writing all the articles right now or about all the new drugs and all the new procedures. So in other words, just because you're going for a second opinion, and it cracks me up, I hear people say to me all the time, yeah, I went for a second opinion to Dr. Vinny Boombatz. I don't know how many of you know who Dr. Vinny Boombatz is. Anybody here know Dr. Vinny Boombatz? Please, somebody help me out here. You're close. That was Rodney Dangerfield's doctor when he went on Johnny Carson. Thank you. Good. At least somebody's awake. Yeah, I went to see Dr. Vinny Boombatz, and he told me X, Y, and Z. And I'm saying to myself, do you know Dr. Vinny Boombatz doesn't know his front from his back? I mean, so people get this information, and they're misinformed, but they go and run to it. Ask the doctor what their thoughts are on alternative medicine. Okay, there's a lot of literature coming out about the use of alternative medicine. It's not voodoo anymore. There are some bases for using alternative medicine. Here's one I'm going to throw out that's going to sort of cause a controversy. What they think about chiropractic? Yes, somebody said yeah. And then here, the last one is holistic medicine, which is different than alternative medicine. Okay? So, I mean, you may be very comfortable with a traditional approach to your healthcare, but you may want alternative approaches. And if your doctor is not on that same page with you, you may feel very uncomfortable, and you may want to consider other options. So, we're almost done about the general stuff. I want to give you a couple of specific GI myths that I'm going to dispel or prove is the case, and then we'll open up the floor or the carpet to questions. All right? Number one, colonoscopy is good. It's very good. No hesitation recommending colonoscopy. I had my colonoscopy. I make sure all my family has colonoscopy. You hear these terrible stories about colonoscopy. I heard this, what was it? This insurance company was saying you do everything to take care of yourself. You eat well, that's tough. You get exercise, that's even tougher. And then you go and have colonoscopy, that's the most difficult thing. Everybody badmouths colonoscopy. Everybody has a horror story about colonoscopy. Colonoscopy is the best test to prevent colon cancer. Okay? It's the best test to prevent colon cancer. Now, that being said, in the spirit of fair play and full disclosure, there are other screening tests to determine whether or not you're at high risk for developing colon cancer. There's fecal occult blood test, what we call FIT, check your stool for blood. There's something called Cologuard, which is this new test where they actually take a specimen and it looks for protein that's abnormal from colon cancers in the stool. But the point is this, if the FIT is positive, if the Cologuard is positive, you still need colonoscopy, all right? And colonoscopy is the only screening test shown to decrease the risk of colon cancer. Remember, none of the other tests decrease your risk of colon cancer. They only tell you whether or not you need a colonoscopy, okay? So number one, colonoscopy is good. Remember that. Number two, probiotics. The jury is still out. We don't know. And anybody who tells you they know, they don't know. They're telling you they know, they don't know. Why do we say they don't know? Because we're just only scratching the surface of what we call the fecal microbiota. Ooh, it's like something Fantastic Voyage. You know, my Lord, I've been a gastroenterologist now for almost 23 years. No one ever thought about the bacteria in the small intestine. We only knew that it was there and that it caused trouble when it wasn't good. Now we're realizing that that bacteria is probably the most important bacteria in your entire body. It controls your immune system. It has, they're talking about things like autism, diabetes, obesity, all sorts of things. So we don't know really yet. We're just scratching the surface. So to say I need to take a probiotic, now, If it makes you look like Jamie Lee Curtis when you're taking Activia, that's fine. I have no trouble with that. On the other hand, it can still give you gas, it can still give you bloating, it can still throw things out of whack. So when probiotics, people say, do I need a probiotic? I say not necessarily. So you have to think about that. Along those lines, we don't need so many antibiotics. That's the problem. We're taking probiotics because we're taking too many antibiotics. Okay? So if you have a sore throat or a cough or a cold, it's probably a virus. There's no reason to go take an antibiotic in the first 48 hours, maybe in the first 3 or 4 days. I don't know how many of you know what diverticulitis is. Diverticulitis is a little hole in one of these little pockets in the colon. It causes some inflammation and pain. Antibiotics used to be the #1 treatment for it. Now they're talking about maybe we shouldn't be treating them with antibiotics. Put them on a low residue diet, liquids until the pain goes away. We're forming these superbugs because they're seeing these bacteria and they're developing an antibiotic resistance to these antibiotics. So don't use antibiotics unless you really need to be on an antibiotic. The body-mind connection is real. You know, when I first started in GI, we used to call everything irritable bowel syndrome. And then people heard that and said, "Oh, you're telling me I'm crazy?" No, you're not crazy. Then we changed it, and now we called it functional hypersensitivity. Ooh, that sounds even better. Where you're just hypersensitive to things. Now it's called functional bowel disease. It's a whole gamut. But the point is this: the brain is connected to the body is connected to the brain. The way you're feeling emotionally influences the way you're feeling physically, and vice versa. If you ever do any surveys, and they ask you before you do the survey, so how are you feeling today? Are you feeling happy? Are you feeling sad? You're feeling depressed? You're feeling optimistic? They use those emotions to then look at your answers and sort of put that information together to come up with a valuable piece of information. So when I tell you, listen, when people say to me, can stress affect us? Sure, stress can affect us. I feel sicker when I get depressed and anxious. Well, sure, it's all interrelated. And they've done studies to really show that that's the case. The hot topic now is proton pump inhibitors or Prilosec or Nexiums or stuff like that. Everybody's talking about that. There's been an attack. I don't know who started the attack on all these drugs. So if you've been on Prilosec, if you've been on Nexium, Prevacid, et cetera, these drugs have been out on the market now for 30 years. Over the last 5 or 6 years, they've caused everything from the uprise of ISIS to the Syrian collapse. I mean, it's just incredible. So the point is this: if you're going to read side effects and you're going to have your friends say, stop the drug, did you hear it causes osteoporosis? Or stop the drug, it causes dementia. Or stop the drug, it causes renal problems. First of all, you have to read the literature carefully. A lot of what you see that gets published is what we call garbage. There's a lot of garbage being published in the literature these days. And most of what you're seeing when it talks about these drug relationships and side effects, it's not cause and effect. It's a casual observation. So in other words, they took 10,000 patients. They tried to match them for age and medical issues. And in one group who wasn't taking the drug, the other group was taking the drug. The groups who were taking the drug had more dementia, so it must have been from the drug. There's not direct cause and effect. So I have more people calling me in my office, I ought to run a tape, who said to me, "Doc, I'm having terrible heartburn." Well, you still taking the acid pill I put you on? No, I stopped that. Well, why'd you stop it? Well, the pharmacist said it causes dementia or it causes kidney trouble. Kidney trouble, that's a little bit more something serious. We ought to think about that. But dementia, osteoporosis, C. difficile diarrhea, I said, and now that you're off of the drug? Well, my heartburn is terrible. I said, go back on the drug. So I said, yeah, but what about the side effects? I said, it's a drug. Every drug has side effects. Tylenol has side effects. You take too much Tylenol, you could develop liver failure. Baby aspirin has side effects. You take it long enough, you could develop an ulcer, 21% increase in stomach ulcers from baby aspirin on a chronic basis. So the point is this: you have to understand, if you need the drug, you need the drug. If you don't need the drug, you don't need the drug. You shouldn't be taking the drug. If you don't need it, don't take it. If you need it, you should be taking it. Okay, here's the big epidemic in the United States, the metabolic syndrome. Okay, what's the metabolic syndrome? It's if you walk into any Burger King, McDonald's, or O-Town buffet, it's the fat person sitting there who needs 2 seats to put their rump down, overweight, diabetic, high blood pressure, elevated cholesterol, and typically has some sort of fatty liver. It's the dirty little secret. In the United States, we're going to be doing away with hepatitis C in the next 20 years. We have drugs now that cure it, which can get me segue to my last point. Soon, the most common cause of liver problems is going to be fatty liver, because we just overeat, we don't exercise, we don't control our cholesterol, we don't control our diabetes, and you need to do that thing. Which brings me to the hepatitis C, which is my last point, and then we'll open up the floor for questions. I don't know how many of you are baby boomers. Baby boomers are defined as being born in 46 to 64. So I'm a baby boomer. You should be screened for hepatitis B and C. If you've not, you need to tell your doctor, I want to be screened. Medicare covers it. One-time screening you should know. Hepatitis C is a silent epidemic. Many moons ago, when I first started treating hepatitis C, 30 years ago, my God, we didn't even know it was hepatitis C. We used to call it non-A, non-B, and we didn't have a good treatment for it. We used to give people injections that made them sick, and we only cured it 20% of the time. Now we have one pill. You take it once a day for 12 weeks, 98% cure, and it's tolerated wonderfully. So that's for C, okay? So you need to get, so if you have your internist, and next time you go in there and you say, you know, I went to this talk by this good-looking young man, make sure you say young, and it commented I needed to be screened for hepatitis B and C. Have I ever been checked? Make sure that they get checked. I just had a patient come in to see me. I mean, it's a horror story when I think about it. He's in his mid-50s. He's had open heart surgery 3 times at Deborah Hospital. Okay, came in to see me, his platelets were low. So I said to him, I said, how long have your platelets been low? He says, 10 years. I said, anybody ever check you for hepatitis? No, they say it was probably related to my surgery. I checked his hepatitis C. He's got pre-cirrhotic liver from hepatitis C. No one checked it. So it needs to be checked. Don't assume. I tell you, don't assume. So that's all I got to say in my prepared remarks. If anybody has any questions that's not related specifically to their medical history or illness, all right, I'd be more than willing to answer the questions. Yes?
Yes, the hepatitis C medication we were talking about is a drug antiviral thing?
Excuse me, the hepatitis C?
Yeah, medication is a drug antiviral thing?
It is an antiviral. It's a brand new class of drugs, only been out really for the last 3 years. It's what we call direct-acting antivirals, brand new stuff. It's really amazing what has taken place in my lifetime. I was at a conference in the city. It was a joint conference run by the International Infectious Disease Society and one of the liver societies. And there was maybe 250 people there, and they were they said, so how many people have been taking care of hepatitis C for 5 years, 10 years, 15, 20? And then they said 30, and it was me and maybe 2 other people. And the guy said, this is unique in the entire world of infectious disease, that within 30 years we've identified a virus and actually found a cure for the virus, because it never happens that quickly.
Talk about second opinions. What happens when you get second opinion and it differs from first opinion to a great extent? Who makes the decision? I know it's going to be me, but I'm uninformed.
Let me ask Brock.
Could you just repeat his question?
Yeah, right. So I was going to say, great question. So you go for a second opinion, and the second opinion comes back diametrically different than what your impression is. I think then, at that time, you have a choice of doing one of 3 things. 1, asking the doctor to confer with the other doctor. Okay? 2, getting a 3rd opinion, so you got your tiebreaker. Okay? And I'll tell you a story about that. Or 3, you're on your own, you need to make your own opinion. My mother, God bless her, my mother's 87 years old. My mother goes for multiple opinions until she hears the one she likes.
Well, most people probably go that way.
I understand that.
You
People
what you want to hear.
I agree 100%, but that's not always the right case. But you know, if things are diametrically opposite from that opinion, there's something wrong somewhere. I mean, you know, most of the time you could sort of say there's more than one way of handling something, but if somebody says, yeah, you need to have surgery, and somebody says, don't worry about it, it's nothing. That's a little, you know, if it's nothing, tell me why it's nothing. Tell me what you did that proves to me it's nothing. Tell me what your certainty is. In other words, if you tell me, oh, it's 80% likely that it's nothing, can you live with 20%? If you can live with 20%, then leave it alone. But let's see if we can get into the 90 percentile. Maybe we need to do a biopsy. Maybe there's something else we need to do. Yes?
If you're older than a baby boomer, do you still need to get screened for hepatitis B and C?
So the question was, if you're older than a baby boomer, do you need to get screened for hepatitis B and C? It depends what you did when you were a youngster. In other words, if you're a wild chick that used to fool around with multiple men or women, or if you used to snort cocaine or heroin, or if you tried IV drugs, or if you were a shooter and a hemophiliac, then you probably should be screened. But if you were a boring Brooklyn housewife who didn't do much of anything else, probably not. Yes?
Can doctors only refer a person to a nutritionist, or can a person do that on their own?
Great question. Can a doctor refer a patient to a nutritionist? Finding a good nutritionist is difficult, one. Two, finding a good nutritionist who takes insurance is even more difficult. I think a patient should be able to refer themselves to a nutritionist. I don't think a doctor needs to. So I would love to have a nutritionalist available to me, especially for my patients who have celiac disease, which we didn't talk about. I'll give you a 30-second spiel about celiac, because that's very important. And in fact, that's even recommended that if you diagnose somebody with celiac, they should be seeing an experienced nutritionalist. So celiac disease, that's gluten sensitivity. It's the big topic. Everybody's going gluten-free. All right, here's my shtick on that, okay? If you think you have celiac disease, you should be tested for celiac disease. Don't just put yourself on a gluten-free diet. You're doing yourself a disservice, okay? For two reasons. One, it's not so easy to be on a gluten-free diet. And two, if you have celiac disease, you're at risk for developing other problems. So you should really know and be confirmed whether or not you have celiac disease. Okay, that's number one. Number two, you may not have celiac disease and you could be gluten sensitive. Celiac disease is an autoimmune process. It doesn't mean you're allergic to wheat. It means that wheat causes you to develop an immune response in your system that causes you to have all sorts of problems. So you could be sensitive to gluten. There's actually something called gluten allergy. If you're a baker, you develop what's called yeast asthma from inhaling the gluten. But if you could be gluten sensitive, and if you go off gluten, you feel better, but that doesn't mean you have celiac disease. It gets a little into gray zone, and it's certainly worth a conversation with your doctor. But understand, gluten has some positive properties. People who go gluten-free when they don't need to develop some deficiencies of nutrients and other important vitamins. Next question? Yes?
Overdiagnosis and overtreatment. Many times I feel you go to a doctor and he's going to test you to the point of almost failure.
These are great questions. I'm glad you showed them. Overdiagnosis and overtreatment. Why do we overdiagnose and overtreat? Two reasons. One, we're afraid of being sued, and the patients don't want to accept no for an answer. That's the bottom line. Okay? I can tell you right now, and we didn't even talk about that because that's a whole different conversation about medical malpractice and stuff like that. I would say if you speak to my colleagues, they will tell you about 20 to 30% of what they do in a day is defensive medicine. Ordering the extra tests. Read a report from the radiology group, and I know all my radiology colleagues here, and no one's here, thank God. They couch their reports. Could be X, could be Y, could be Z, suggest getting ABC, because they're afraid of getting sued. So if they're afraid of getting sued, and they're saying maybe get another test, then I'm going to end up getting the other test. Now, if I say to the patient, listen, I don't think this is anything with anything. Well, how do you know? It's my experience. Well, could it be? Of course it could be. Well, don't you think you ought to find out? Well, that means I got to order X number of tests. Whenever I order a CAT scan for somebody, which I feel is going to be, I'm not going to find anything serious, I say to them, listen, are you prepared to deal with the dreaded incidentaloma? And they say, incidentaloma? What's an incidentaloma? I said, incidentaloma is an incidental finding on the CAT scan that means nothing that's going to affect your life. That has been sitting there probably for 20 years. That'll probably go into the box with you when you pass along at age 90, God bless you. But because I found it, I have to do further tests. It's the dreaded incidentaloma. And sometimes they say to me, you know, maybe I don't want to know. I say, okay. And then, you know, it happens all the time. You find these things, it means nothing. But for every 10 incidentalomas, there's 1 or 2 patients walking around who call me God, not my mother, but they call me God because I ordered a CAT scan for some other reason, and I found something else that we picked up early, like a renal cell cancer or an ovarian cancer or something else when they came with vague abdominal pain. So, you know, everything has to be weighed. A lot of it goes with clinical judgment. A lot of it goes with the relationship of your patients. There's a lot of people come in and say to me, listen, doc, I ain't going to sue you. Don't worry. Those are the ones I get the tests on immediately. Because when they say I ain't going to sue you, you never know. Those are the ones you always have to sometimes over-test. It's the nature of the beast. But you're right, those are good questions.
Okay, I have a quick question.
You can take a small question.
Okay, if the patient got on with the medication and then having improvement in many aspects,
right,
and wishing the doses to come down or even quit the medication, and has all the evidence to show the doctor, but however the doctor doesn't really interested in that. How can you get the doctor's attention that take me serious? I have been doing so much effort, you know, or what?
No, I think that's a good point. I mean, you're talking about at that point. Again, the question is, if the patient is doing well and they want to taper their drug or stop their drug, and the doctor is not open to that, what do you do? I mean, I think that has to do with your relationship with the doctor. I mean, any doctor who says to you, listen, there's certain drugs you can't stop. In other words, for example, I have patients with inflammatory bowel disease, Crohn's, ulcerative colitis, and the studies have shown if they're in remission, they're better off staying on the drug. So, you know, young people especially say to me, Doc, do I really have to take 3 or 4 pills? So I say, okay, let's take 2 pills. So now a year goes by. I say, Doc, do I really need to take 2 pills? Okay, you take 1 pill. So another year comes by. I want to stop the drug. I said, really? I'm not quite sure you should do that. Well, but I'm tired of taking that. I've been in remission for 5 or 6 years. My argument is, you know something? Whether I tell them to stop, not to stop the drug or not, they're going to stop the drug. So I say to them, listen, stop the drug. Understand that you may flare. It's a chance you're going to take. Let me know if you get more diarrhea or cramps. So I think it has to do with communication. And if you're not communicating with your doctor, that's a good reason to find another doctor.
So I appreciate you mentioned about immunity, but I'm talking about high blood pressure, for example, that's high.
Oh, high
and you
blood
can
pressure.
actually coming down, and you show all the blood pressure logs and exercise, eating well, and weight loss, and all that for whole shebang and for the whole time.
The whole shebang. Yeah, you know, more people get into trouble because of the whole shebang than. I have to see what the CPT code is for the whole shebang. If the government pays you for the whole shebang. And no, I understand everything you're saying is true, and not so much with high blood pressure. You know where I see it more with cholesterol medication. Patients don't want to take cholesterol medication. I went to see my physician, and I go every year, which is weird because most doctors don't. When I walk into his office, the nurse says, do you need to speak to the doctor? I say, I'm here for an exam. They say, well, really? Why are you here for an exam? I said, no, I believe in an exam. So my cholesterol went up to 202. It was never above 180. So he knows I don't take any medication. So he says, I'm not going to start you any medication. Just watch it. We'll keep an eye on it. That's a relationship you need to have with the doctor, and you need to work with that. But let me also point out something about cholesterol. If somebody comes in my office and they're taking a cholesterol pill, and I say to them, do you have any medical history? And they say no. I say, well, what about the cholesterol pill you're taking? Oh, but it's under control. I said, yeah, but if you stop the pill, it's going to go up, right? So you have cholesterol problems. So people don't think upon these things as a problem. So I think you sort of need to maintain the lines of communication. And if listen, it's your body. The worst thing they're going to do is say, well, why'd you stop the pill? And they're going to come up to you, why'd you stop the pill? And then, if you like them, You say, oh, I'm sorry. And if you don't like them, you say, don't talk to me like that. Anything else?
Yes. Let's talk about the doctor visit. I feel that most times it's too short. The doctor is...
I mean, when you come to see me, it's too short?
No, I'm not talking about you.
Oh, but you got to make them aware of that. You know, it's...
All right. The doctor is sometimes being interrupted, but he's in his 5-minute time zone, 10-minute time zone. You feel you need more time. How do you handle that?
I'm taking a deep breath because every time, because it's not such an easy question. I think it depends upon how long you know the doctor. Do you feel comfortable talking to them? Do you say to them, hey, listen, you know, last time I came in, I felt rushed. I said, next time I come in, I'd like to spend a little more time with you. You think you can find some time for me? You know, listen, despite my jovial, wonderful personality, don't laugh, there's days I'm not at my best, and I'm stressed, and I'm frustrated, and I'm, you know, so maybe you caught the doctor on a bad day. If it's a continuing problem, you need to say to him, hey, listen, I'm not getting what I need from you here. I said, I think you're a wonderful doctor. If you can give me more time, that would be great. If you can't give me more time, I may need to consider making a change.
Is it okay to call the doctor after hours with a question?
Depends what kind of question it is. And I'm not being funny or flippant. I mean, nothing frustrates me more than I sit there and spend 20 minutes talking to a patient, and then they go out and they call me 20 minutes later about the same thing I just had a conversation about. Now, listen, if you didn't get the information, you didn't get the information. If you're a little bit confused, you're a little bit confused. You know, I'm from New York. I talk with a Jewish New York accent, and I talk quickly. So sometimes maybe you don't understand me. So if you need clarification, I'd rather you clarify something than make a mistake. So I don't think it's unreasonable. Not at 10, 11 o'clock at night. And not at 5 o'clock either. You know why? Because here's the point. 5 o'clock is like the witching hour. It's when the office is ready to close and they're turned over to the service. So when you get a call at 5 o'clock from a patient, the first thing you say as a doctor is, geez, why didn't they call earlier? Or why didn't they call later? It's 5 o'clock. So yeah, you're entitled to call. And you should call. It's better to call than make a mistake. But, you know, be reasonable. Anything else? Well, thank you for your time. I hope you got something out of it. I hope it was all valuable for you. Thank you.
Thank you so much for watching this presentation. I hope you found it highly informative. And remember, the library is always here to help you find answers to your health and wellness questions. We are part of the National Network of Libraries of Medicine, and you can reach our consumer health librarians anytime at our website at www.welllinks.org or during library hours by calling the information desk at 732-390-6767.